Good morning. Hi, everyone. This is Becky with Rochester Mom, and I'm here again this morning with Dr. Melissa Richards. Good morning. How are you?
Good morning, Becky. I'm great. How are you doing?
I'm great. Despite the fact that it's cold and blustery out there, I am confident that spring will join us at some point. So, for those of you who have not joined us for one of our Know Your Body segments with Dr. Richards, we this year are going through all sorts of things that we want to empower you with the knowledge to know what is going on with your body during the normal course of womanhood. Maybe you are thinking about having babies. Maybe you are expecting now. Maybe you're done having babies. What happens when you hit menopause and after? So, we have been talking with Dr. Richards, who is the chair of the Obstetrics and Gynecology department at Olmsted Medical Center, through these fascinating topics. So this morning, we have decided that we want to share some things with you that you might not have heard about, or you might not be expecting. So many of us have heard about What to Expect When You're Expecting, the book that all of us kind of get given when we find out we're expecting. But today we want to talk about things you might not have heard about regarding expecting a baby, especially in your second and third trimester. So before we do that, we want to talk through some terminology you may encounter during your prenatal visit. Specifically, what does it mean to be preterm, term, and postterm? What do those mean, Dr. Richards?
Great. That's a great question that I think a lot of us as clinicians take for granted. So at the beginning of your pregnancy, you get an estimated due date. And typically that estimated due date is decided upon really either using your last menstrual period. Now, using your last menstrual period, we think 40 weeks. So that 40 weeks comes from the idea that you probably ovulated 2 weeks after the first day of your last menstrual period.
Yep.
Right? Exactly. Or we base your dating on an ultrasound that's typically done before 20 to 22 weeks. A lot of times we're doing it in that first 10 weeks of pregnancy. That gives us an estimated due date, or EDD. And that's just what it is. It's an estimated due date. But when we really think about it, you're kind of due for about a month, like any day within a certain period of time. So that means starting at 37 and 07 weeks, so 37 weeks on the dot, that is term, and we give that a term called early term. So any delivery prior to 36 weeks and 6 days is considered preterm. You start your third trimester of pregnancy at about 28 weeks. So anytime up until 37 and 0, you are considered preterm. And then we're 37 and 0 up until 38 weeks and 6 days. Then you fall into full term. Full term, I know, right? So full term is 39 and 07 weeks. All right. And then we get to 41 weeks and 0 days. Then we're considered late term.
Okay?
Late term. And then when we get to 42 and 07 weeks, if you're still pregnant, you could still be pregnant. That is called postterm. So it gets, as we continue this conversation, we as clinicians are always thinking about, okay, if we're making decisions about this pregnancy, is she, early term? Is she late preterm? I left that out. That even makes it a little bit more confusing.
Late preterm.
Late preterm. We're not even going to dive into that, but that is also one of those fun terms that we learn in residency. But there is, when we're making decisions on when to have a baby, these are all words that we're using in documentation that sometimes we just kind of take for granted. But if you're interested in that as a patient, we're happy to give you that information about, okay, I'm 39 and 2 today. What does that mean, Dr. Richards? I'll be like, that means you're full term.
I did not know that you could still be pregnant and be considered postterm. I think that's really fascinating.
Right?
Yes. So with my first, I was 42 weeks to the day when actually, I think it was 42 and 1 to the day of when I delivered my first. And so knowing that it was post-term, I suppose doctors are like code for she needs to have a baby soon.
Yes,
Right.
exactly.
Right. So,
Yeah,
heading into kind of talking about these second and third trimesters, which we're kind of focusing on today, there are some things that happen during your second and third that make it really unique that don't happen in the first. And we've kind of all encountered these things, but maybe we don't know some specifics. So, weight gain, swelling, new body odors, what's happening during sexual intercourse, why it feels different. So, I thought maybe you could chat about those sorts of things.
absolutely. So we talk a lot about weight gain at the beginning of pregnancy, expected weight gain. Those recommendations are oftentimes made on your pre-pregnancy weight.
Mhm,
So anywhere between, we have some patients who don't gain any weight in their pregnancy.
mhm,
Um, and for some patients, that's perfectly fine. And for other patients, that's not. And we want to you look at that whole situation, each
mhm,
patient individualized. Expected weight gain 15 to 25 pounds or 25 to 35 pounds. Well, these are expected or recommended weight gains, but we see a whole range of patient weight gains as the pregnancy progresses. Some of that weight gain is actually fluid based.
mhm,
So when we talk about swelling, the fancy medical term for that is edema. And we have all these blood vessels going through our body that are carrying oxygen through our red blood cells. And sometimes, especially in pregnancy, they get a little leaky and some of that fluid sneaks out of those blood
mhm,
vessels or out of those pipes. And we get this edema. When you're pregnant, your body's super smart and it actually adds fluid volume.
mm,
So you put almost like 3 liters of fluid on your body when you're pregnant.
mhm,
And that helps prepare for delivery, because delivery, we can have some fluid loss
mhm,
when we have our babies. So that's sometimes where that weight comes from. But I really encourage patients, when if they have concerns about not gaining enough weight or gaining too much weight, the importance of, let's look at trends. Let's look at the trend, not over 2 weeks or 1
mhm,
week. Um, let's look at the overall trend. Sometimes a 1 week change is a big deal, but sometimes it just means we need to see what the following week
mhm,
brings. Vaginal discharge, especially when we enter the second and third trimester, can be impressive. There's a lot of thoughts behind why do women have that
mm,
as they get further into their pregnancy. We think there might be a protective factor actually with that
mm,
discharge. Discharge that concerns me would be concerns for like bacterial vaginosis or vaginitis or a
mhm,
yeast infection.
mhm,
So it's really common for women when they come in, they're like, yeah, I've got some increased vaginal discharge. And then my follow-up question always is, okay, do you have any pain or
mm,
burning, other symptoms? Because that vaginal discharge is probably fine.
mhm,
And then the other thing people think about with this increase in vaginal discharge is, there water breaking? Is that my
yeah,
water? Has my
mm,
water broken? And so what I like about when patients have those concerns is it gives us a chance to like talk about it, right?
sure, yeah,
Exactly. For myself personally, I'm going to give some personal information. Like
mhm,
one of the big things that first time moms especially have is like, how will I know if my water is broken, especially
mhm,
if I'm now wearing a pad because of this increased vaginal discharge. That's what happened to me. My water broke. I did not have contractions with my first child. My water broke. And like I like to tell patients, you'll know. Like
yeah,
you typically will know. And if you don't know, that's fine. Give us a call, come in. We'll do
mhm,
a workup to make sure. But typically you'll know.
yeah,
You'll know.
yeah,
I say there's like a water breaking walk that you will do.
right.
Goodness gracious. It's
My,
not the gush like you typically see on TV. For some people it is, but it's a change. It's different than normal vaginal discharge or peeing your pants a little bit.
right.
Mhm.
For
Uh,
me, oh, sorry, you're not done.
oh, I know. I'm like on this little roll
Yeah.
here. And then I'm going to pivot just sex.
Yep.
So sex in the second trimester, third trimester, it's a different experience for a lot of people. Some people are like, sex is amazing. This is so
Mhm.
great. And some people are like, we're not having sex for a very long time. Both are fine.
Two ends of
Like,
the spectrum.
exactly. I have a lot of patients who will be concerned about having sex, would that cause, pain to the baby, or can that cause issues? Unless you've been put on pelvic rest or not to put anything in the vagina, we're probably not going to run into issues. So I unless you've had specific recommendations from your clinician, sex is typically fine, but you're also in charge of that, right? So if you don't have sex, you don't have to have sex.
Yeah. Right.
And it's fine, just fine too.
So it's good to know that in this spectrum, there's a whole lot of normal.
Absolutely.
Right?
Totally.
So much normal, even going back to body odors and vaginal discharge, a whole lot of normal. And I love that you called it impressive. You got some impressive discharge and and new body odors, all normal, all within that spectrum. And so if you're concerned, always ask your primary, always ask your physician, your OBGYN, and they can help you determine, especially with a water breaking one. I think a lot of us who are expecting for the first time are like, what does it mean? What if I miss it? What if
right.
I did have one of those movie water gushing moments.
Did you?
I
it was
did.
Pretty wild.
Yes, it was during a particularly hard contraction. And all of a sudden I was like, oh boy. I was standing up, leaning over the bed, and whoop, there it went. That was entertaining, I think, for all involved. So we're going to head into now some things that may happen during your pregnancy and what you can expect if it does. Now, these things may happen or may not happen, but we want to prepare and equip you for when it does. So, Dr. Richards, sometimes babies need extra monitoring. What can someone expect when this happens?
Right. So this is a great question that I think, once again, we as clinicians, whether you're seeing your family practice person, the nurse midwifery team, or the OBGYN physician group, we sometimes take for granted a little bit. There are mom conditions and baby conditions where, especially in the third trimester, we might do extra monitoring. Sometimes what we'll do is we'll monitor a baby for growth. And we'll do that depending on the situation every 2 weeks, or oftentimes every 4 weeks, maybe even every 6 weeks, just to make sure that the baby is growing appropriately. And then sometimes after 32 weeks or 34 weeks or beyond, we have you come in once or even twice a week to monitor the baby for 20 to 40 minutes, looking at the heart rate. We're looking at very specific patterns in the heart rate, and also looking at the fluid around the baby. What that tells us when we're looking, I'm going to get kind of sciencey. I'm going to try not to get super sciencey. I got my doctor getting all psyched here. Okay, so let's touch on like why, right? So like, why would we do this? Okay, so mom reasons. Sometimes moms develop blood pressure issues in pregnancy that they either have before pregnancy or during pregnancy. So we want to make sure that that's not affecting the baby. Sometimes women will get diabetes in pregnancy. That gives us a reason to watch the baby a little bit closer. Sometimes previous deliveries or previous pregnancies make us watch the baby a little bit closer. As I kind of touched on, sometimes with babies, depending on if the baby's growing maybe a little bit smaller than we'd expect, that's a reason from a baby standpoint. And so what we would do is we'd, as I said, have you come in and we're watching that baby, the heart rate on the monitor for 20 to 40 minutes. And that kind of gives us an idea, how is this baby doing right now? How are we doing right now? And then we're able to also, after we do that part of it, that's called a non-stress test. We here will typically look at the fluid around the baby at least once a week. And what that tells us, if you think about what's happening, is blood flow through mom, goes into the uterus to the placenta, and then goes through the umbilical cord, and then circulates into the baby, and then circulates through the baby, including the kidneys. And then the kidneys filter, make urine that goes down in the bladder, and then the baby pees while it's in the uterus, and that pee makes up the amniotic fluid. So this is sometimes a big like for some people that we now realize that we all swam in our own sterile pee.
Sterile, right? Exactly.
We swam around our own pee, and then not only did we swim around in it, we swallowed it.
Oh,
and
fascinating!
Then
fascinating.
I know, it's pretty cool.
The body is wild.
It is pre and post delivery.
Right.
And so when we look at that monitor, that non-stress test, and then when we look at the fluid around the baby, that gives us what we call a modified biophysical profile.
Okay.
And if both of those are reassuring, I can look my patient in the eyeballs and look at the partner and say, I think that baby's doing well, that we can stay pregnant for another week. Like, I'm not concerned that something is happening, or there's a decrease in the ability of the placenta and how the baby is doing. So it provides us with reassurance. Now, on the flip side, if for some reason the baby isn't doing what we'd expect, or if the fluid looks lower than we'd expect, that does not mean anything bad is going on. And that's really important to know, because in some situations, that just means that maybe instead of waiting a week, we're going to have you come in tomorrow.
Okay.
To reevaluate, or it might even mean today we're going to do a special ultrasound to give us reassurance. Because sometimes the reason the heart rate isn't doing what we think it should do, the kid's tired. The kiddo is taking a little napper. Right. And that's where we don't see those normal changes in the heart rate. That we want to see during that period of time. We get an ultrasound, the baby looks great, and then we say, see you in a week. But that I oftentimes will see that when I'm doing a little visit and someone has just done this non-stress test, saying, do you know why we're doing this? No, but I know I'm supposed to do it. So I think when you understand this is for reassurance, it makes you feel good. Because obviously this pregnancy has maybe become a little bit, maybe not what you would have expected. But the whole idea is keeping, pregnancy safe, you safe, and getting to our end goal of having this little human out that we get to love up.
Lots of really fascinating tidbits there that we just learned. Yeah. So on to another question, or is something that can happen is sometimes your doctor, OBGYN, will recommend an earlier delivery. Can you speak on that?
Absolutely. So here at OMC, we have, our OBGYN physicians. We also have our midwives. Both groups will, in different situations, recommend an induction of labor. So with our current patient population, which reflects nationally, blood pressure issues tend to be a big reason why we recommend delivering a patient earlier than we would wait until labor just naturally happens. And then diabetes tends to be the other big factor. Our patients are becoming a little bit older. So what this term that we give patients, advanced maternal age, is another reason. So it's really nice because there are some guidelines out there that tell us, in the setting of high blood pressure in pregnancy, we recommend induction of labor at 37 weeks. So that early term diagnosis. Sometimes if you've had a previous cesarean section, depending on the incision on the uterus, we might actually recommend late preterm or early term delivery. But they're very specific, and we do, I think, a fantastic job here of following these national guidelines that have good evidence-based medicine behind them, and then also using the support of Dr. White, our perinatologist, whether once again you're seeing one of our certified nurse midwives, one of our nurse practitioners, our family medicine physicians, or the OBGYN physicians. She helps just do a great job of guiding, especially in some of those situations where maybe we have a couple things going on. What I think is also really important is we make recommendations. We explain what those recommendations are, but we also want to make sure that you as the patient, it makes sense and that you're giving consent for whatever we're recommending. Absolutely.
And that you're really in the driver's seat. And I think that that's what I love so much too about the care at OMC, is that it is so informed by your body and what your body needs and what the individual needs. And it's not some protocol that you're following. It's really specific to exactly what the expecting mother needs as they go to preparing for delivery. So you touched on this for a second, but I want to circle back to it. Sometimes women do need to be induced. And this runs the gamut. People are sometimes truly devastated when they hear that this happens. Some people may just not even know what it means. So Let's clarify that a little bit.
Absolutely. So in these situations, and sometimes another group would be like, I would like to be induced too. We have that
Right.
many
Yes. Let's
population
go.
too.
Yep.
We're like,
Done. Yes.
I'm done.
Right.
So I do want to touch on that patient population because I think that's important. So those are patients who are requesting an elective induction. So we don't do elective inductions until after 39 weeks. So we don't do them. Like we don't do them. There's great data to support that. There are even laws
Mhm.
that. So an elective induction happens after 39 weeks if there's a request for that. Our induction process is making sure we have informed consent. And then when we will find, usually there's almost like a range, like for diabetes example, gestational diabetes. It's not that we have to do your induction on this specific date. There's like a range of a week or a week and a half or even 2 weeks in space. So let's say we decide, okay, we're going to recommend an induction of labor. So we will pick a day, hopefully a couple weeks ahead of time, or even we have our planners. So we'll pick a day like a month or even 2 months ahead of time.
Yeah.
And then we've got our penciled in date.
Yep.
And then here at Olmsted, we're gonna get kind of into the nitty gritties. The night before your induction, you would get a phone call from one of our OMC nurses who would say, hey, you're coming in at 8 a.m. They'll give a couple instructions and then please give us a call at 7 a.m. And we do that just because we want to make sure our birth center is ready for you. And sometimes we'll say, you know, when you call that following morning, can you come in at 10 as opposed to 8, just because we're doing some staffing optimization. When you come in, you'll be met by one of our awesome registered nurses. They're so good. They'll get you admitted. They'll get to know you a little bit. And then typically one of your clinicians is going to come in the room and do an exam to see what our first steps, next steps will be. We're going to get kind of sciencey. Are you ready?
I'm ready.
Okay, cool.
I'm ready. Here we go.
All right. So we're going to check your cervix. So what does that mean to check a cervix? So everyone thinks about like how dilated the cervix is. So the cervix goes from being nothing or completely closed, and sometimes we'll call it fingertip, to 10 centimeters. Okay. So everyone thinks about dilation, but there are a couple additional things that we're paying attention to. We're paying attention to your cervix is kind of like a little toilet paper roll.
Sure.
Yeah. Right. So not only is the dilation, but how long the cervix is, how soft the cervix is, what it feels like. Does it feel like your nose or does it feel more like your lips? How far down the baby is in the pelvis. So the baby goes from negative numbers. There's something called station. So we go from like -5 station all the way down to 0 and then all the way up to +5. That means the baby's coming out. And then also the position of the cervix. So typically, and women who've had their cervix changed will know, checked, I should say, know exactly what I'm talking about. If it feels like the clinician is reaching for your tonsils, that means your cervix is probably posterior. And then as you're getting closer to your cervix becoming more favorable, it'll move anterior, move towards from the back all the way up to the front. So what I did right now is I mentioned 5 different things. So how dilated, how thinned out the cervix is, how far down the baby is, the location, then how far down. I don't know. There are 5 things. Typically, when we check your cervix, I know right away if a cervix is favorable, meaning if we started a medication called Pitocin or broke your bag of water, the chances of you having a vaginal delivery are the same as someone who walks in labor, which is awesome. That's called a favorable cervix. And then I know if I check your cervix and I'm like, it's not favorable, not as favorable, then I know we need to do let's do some what's called cervical ripening, get the cervix ready for either breaking the bag of water or starting the medicine Pitocin or oxytocin. And we can do that cervical ripening. I kind of refer to that as like the pregame. We can do that with some medicines that we place inside the vagina that help kind of get your body to release the prostaglandins, the cytokines, all that good stuff that helps soften the cervix. We even have a little, what's called a Foley bulb catheter, a little catheter that we can place in the cervix and help dilate the cervix for people who want to avoid medicine, or there's a reason we're trying to avoid medicine. I just did an induction last week, and I I think what kind of blows us all away is the amount of options that we have for
Yeah.
induction labor. And there's also what I find also interesting is we used to do only one thing at a time, or maybe you do two things at a time. And you've got options. We can kind of customize this to the induction, because this oftentimes isn't part of your plan. No one wants to be induced. Typically.
Right.
Like, I shouldn't say no one, but most people are not too keen on being induced.
Right.
So trying to figure out, okay, this is where we are.
Mm-hmm.
And how can we make this into a positive experience? And
Right.
the nice thing is we've got great data here to
Mm-hmm.
show that we do induction of labor very well. And I
Mm-hmm.
see that in our patient responses about their experience, but also like hard objective data in our very low cesarean section rate and our hospital stays.
Yep.
Yeah.
It's like your menu of induction, like
It's sometimes it's overwhelming, and sometimes I actually take a moment to say, would you like me to give like my recommendation in this setting? Well,
yeah,
we don't have to do it, but here are my thoughts.
helpful, because it's a lot to go through.
It is.
But this was really good. This was a super informative know your body session. And all of this, we keep talking about it, and we're going to keep talking about it. It's so you are equipped, so you are empowered, so you have the knowledge to make these decisions that you've consented, that you know about, that you feel confident in. That is why we continuously bring you these know your body sessions. Dr. Richards, thank you for a particularly fascinating discussion this morning. And for all of you that have joined us, thank you so much. If you have any questions, you can post them in the comments below, and we will see you next time for Know Your Body. Thanks, Dr. Richards.
Thank you, Becky. This was great.